My name is Darlene Hamill. I'm a family doctor, and going along well with this forum is that I've been in practice for 40 years, so you figure out how old I am. The first thing I'm going to answer myself, which is Make Your Day Harder. Is it a book, a television? What is it? Google Mike Evans. Mike Evans is a family doctor at St. Michael's Hospital in Toronto, and he is really keen on patient education, getting people moving. Make Your Day Harder is a YouTube video, right? And he has another one, the 23-and-a-half-hour day, that is brilliant. What he's doing is talking over top of a cartoonist who's drawing, and you can't stop watching it. It's excellent. So Mike Evans. Well, there are two YouTube videos. Make Your Day Harder. Do you want to answer?
Yeah, I think the website, I'm just going to verify this for you. I believe it's My Favorite Medicine, all one long word, .ca. myfavoritemedicine.com.
Is that his website?
It is.
So then you should find the other videos linked to that.
And he has a number of videos in addition to Make Your Day Harder on melanoma and diabetes and so on, and all are impressive.
So my first question is a combination of questions, and it is going to go to Dr. McDonald, although the way we often do this is that other panelists can put their opinions in as well, and I will encourage them to keep their answers brief so we can get through more questions. So is it necessary, Dr. McDonald, to always work to increase what you're doing, whether it's weights or speed or distance? Do you always have to go harder, or can you reach a place where you just plateau what you're doing?
Well, in simple terms, I suppose if you're an elite athlete, for example, there always is a threshold beyond which you probably can't go. But yes, in short terms, I would advocate that everybody has their own baseline. And I find it far more motivating to compete against myself than I do against others. And I think the health benefits are borne out based on you improving your walking speed to walking more quickly, doing 4 blocks, doing 1 mile, doing 2 miles, and you can do it in a baseline or relative to your own baseline. Plasticity is another important concept, and I think if you plateau, if you don't continue to push yourself a little bit, you won't continue to push the limits of what your potential are. There is an impressive plasticity both in terms of our cognitive function as well as in terms of our brain. And there are constraints that are placed on that as we get older, but it's still there. It might take you a little longer, but it's still possible.
Does it matter whether you do intense exercise twice a week or whether you do less intense exercise more times a week for anybody?
So my answer to that is no. What matters is that you are active. So I think that because of the variability in answers that we receive to that, it's often a way of just not doing anything. And so I think that I personally like to follow what the World Health Organization recommends. And what they recommend is that in order to minimize the chance of yourself becoming sedentary, that you really look at that hour of moving per day. And that 3 times a week, you try and do something that is a little bit more vigorous. The problem with the 3 sort of half-hour spurts per week is that just going for a run, but the rest of the time being on the couch watching reruns, you know, you're not going to get the full benefits.
Yeah, and if I might add as well, I think any opportunity that you can to integrate activity into your life, such as standing during intermission, as my students are going to recognize this term and borrowing from a colleague at the UBC Center for Hip Health, standing meetings, walking meetings, these sorts of things. You don't need to be tied to a chair. You certainly don't need to be tied to PowerPoint slides. And regardless of whether you're retired or what your station is in life, there's a way that we can incorporate those things in. And if you really enjoy television, I suggest getting a recumbent bike that powers your television.
Well, I'm guilty of being someone who exercises very intensely 3 times a week, except that I think the last time I actually did it was about 2 years ago, because I think I do it, but I don't think I actually do it. I think I have the intent to do it. So it's probably better to aim for every day. We had the answer on resistance training. Here's a really good question that 3 different people asked. What if you are really not very mobile? What if you are in a nursing home or have a parent or client in a nursing home? What can you do if you really have limited mobility?
About that. One of my slides at the end was just about this. So my message is that if you are very fit or if you are barely mobile, it's still the same 1 hour per day of moving. So I have many patients who live in nursing homes, and right now I live up in Port Alberni, and when in the nursing homes there, the activity is often half an hour in the morning, just getting up, getting ready for the day. That's activity for somebody who is barely mobile. So doing their basic activities of daily living, getting up, getting washed, getting dressed, walking down the hallway to the dining room. That is part of their hour right there. Building in some walking time. So when you're very frail and aged, just the activity of transferring from bed to a chair is part of their activity for an hour. So if you are that immobile that your transfers are a problem, that is where you start. You know, Stuart's recommendation that you start from where you are and you move on from there. So if it is walking for 5 minutes and then you're tired, that's where you start. And you work up gradually from that. My mother, I'll bring her in here because she is a good example, extremely frail lady who for most of her life did not exercise. And she's now in her 80s, very frail, cannot do much. We started her on an exercise program. Having a geriatrician as a daughter means that you can't escape that. And unfortunately, it led to a bit of tussles, but she got there. And she started with 1 minute per day of walking. She now is active for an hour a day. No, she tells people that her daughter bullies her endlessly. But to date, she is in her home independent. And that was why I became militant on this, is I didn't want her to go into a nursing home. And I knew that ability to transfer would be what would take her out. So that's it.
Thank you. Can computer games improve your cognitive development? Scott, do you have any idea on that one?
Well, there have certainly been a number of studies, and you'll note that there's been quite a commercialization of these computer games. Many things are now available on the web, through our Xbox and various other ways to do this. The evidence is rather weak. What it shows is that people do actually improve, not surprisingly, on their performance on those particular games, on those particular types of tests. And in fact, many of these games are based on neuropsychological tests. But what we don't tend to see is transfer to other types of cognitive function, other types of activity. So you become very good at that one thing. So it doesn't have the same generalized effect that we find physical activity does, which really impacts a whole range of functions and outcomes. So I think the recommendations are really to engage in a variety of demanding, challenging, effortful activities that this is what we should be doing. Don't retract from those. Keep at it. Keep doing the wide variety of things that do take effort, that do challenge you.
Thank you. I think what we're hearing more and more is the cross-training doing not one thing over and over and getting really well at it, but doing as many different things that can stimulate different parts of the brain. Here's one that I think Dr. Williams might take on, and this is an important one. When I started practicing, we would take people off their cholesterol drugs. Not when I started practicing. When I started using cholesterol medication some 25 years ago, by the time a person reached 75 or 80, we would take them off their cholesterol medication because they were too old by then and they weren't going to get very much benefit from it. That's a joke. What are you advising now, Dr. Williams, in terms of the drugs for called statins, and as they may improve cognitive impairment or decrease cognitive decline?
So this is a very good question. It's also a question to answer fully is another hour. So thank you very much, Darlene. But what I want to do is give you a couple of principles to take out here. And I think the best way to answer this is with patient examples. So if you have never been on a statin and at the age of 87, and you're quite frail and you have a heart attack, and we discover that you have some abnormal cholesterol levels, do we start you on a statin at that time? Well, if you see a cardiologist, then yes, indeed, you go on a statin. And I see one of my old mentors, Dr. Broom, here. Very, very nice to see you. And he was one of our very best, and still is one of our very best internists here on the island. And at one point a decade ago, we would have thought, yes, we'll probably put you on that statin. The decision making that we use now, because our evidence is much better, is that if you go on a statin, in order to get benefit from that medication, it takes between 2 and 3 years to achieve that. So if you're very frail and elderly, then no, there isn't really necessarily much reason to go on the medication at that time if we think that your life expectancy is only 3 or 4 years. That's case number one. Case number two is you are a well-functioning 65, 75-year-old who has never been on a statin, and you have a heart attack or possibly a mild stroke, and we identify that you have some abnormal cholesterol or other fats in your blood. Do we want to do everything that we can to prevent you from having another event that may cause significant disability? Well, the answer is absolutely yes. So yes, we would put that individual on a statin and we would follow them to make sure that that medication had been effective in them. So that's patient number two. Do we put people on statins who have not had an event such as a stroke or heart attack and who have normal cholesterol levels just because we think that it may prevent dementia? We do not do that because there is no evidence for that right now. What we do have evidence for is that statins in somebody who has had a heart attack or a stroke, cardiovascular disease with some abnormal fats in their blood, that there is reason to take a statin in order to prevent another event which may be linked to cognitive decline. So when you have a stroke, if within 3 to 6 months you are showing a decrease in memory or other cognitive function, you have what is called vascular dementia. And people who develop vascular dementia are very likely to develop the changes associated with Alzheimer's as well. So I hope that helps a little bit for you to understand that there are no generalities in medicine, that medicine is fascinating for this reason, because every person who we see is different, and judgment is based on the individual in front of you, what is important to them, how they are doing, and what disease burden they carry. Thank you.
Thank you, Dr. Williams. It's a very important question that follows from that. And what I'm going to do, because it's on this same topic, is ask that perhaps you speak to Dr. Williams at the end when the general questions are over, because I think a number of you may have the same question, which is, what's the difference in all these dementias? You mentioned vascular, then there's Alzheimer's, then there's the term dementia, and it's such a big question to answer that perhaps you can ask it of her after the this formal session's over. So to the scientists in the room, are there any serious studies of the benefits of laughter?
Not yet. But I tell you, it's a good topic. But how would you measure that? I guess, how much did you laugh today? Did you?
I'm short of consulting my friend Google. I'm entirely uncertain.
I don't know.
So, but I highly advocate it from a personal experience.
So from laughter, what about calorie reduction? If you're mildly overweight, not obese, but mildly overweight, and you move, should you be trying to reduce your calories?
And this is just my personal preference, and I would always defer to a medical professional as well, but I would always err on the side of engaging in an active lifestyle as opposed to trying to practice caloric restriction. There's certainly animal evidence that shows metabolic changes and caloric restrictions in several different strains of animals by up to 40% can increase your lifespan. But first of all, I'm not going to sign up for 40% restrictions as a human. And second of all, I would have very serious nutritional concerns, I think, in that regard. There are other ways that you can reduce free radicals and oxidative stress and these sorts of things.
The only thing that I would add to that is that if you think that you're mildly overweight, please check with your doctor to make sure that that is indeed the case, that many of my patients who, as they become older, their spines become a little bit shorter. I always ask them, if you have in fact lost 2 to 3 inches, where do you think your guts go when that happens? So you've all got it. Your guts go out. So I have so many patients who are terribly underweight, but are absolutely convinced that they have to lose 20, 25 pounds because their pants don't fit around their waist. So first, check that out. Secondly, check that your your body mass index is within normal range. So have your family doctor check where you are, because I think society does us a great disservice by making us think that we have to be a certain weight. And the final thing on that is go to your local park and recreation center. I didn't get to those slides, but they are tremendous. Our local parks and recreation centers have tremendous programs that everybody in this room can fit into, and they will assess your fitness level. They will do tests on how much fat you have, how much muscle. Find out these details about yourself. And caloric restriction, on the whole, no. Go for nutrition, nutrition, nutrition. Eat lots of power foods, those superfoods, goji berries. Find fun things.
Okay, we've got 2 minutes left for questions. That doesn't mean your questions won't be answered. We would like you to make sure you speak to the speakers afterwards if your particular question hasn't been answered. We have one card full of excellent questions, so I'm just going to pick one of the questions from that. And in a simple way for the lay public, can you explain how I might know how my cognitive changes are being measured, or how, if I went to my doctor and said, could you please measure my cognitive function or my cognitive changes or decline, what would the doctor do? They're trying to figure out the answer.
This is really a great question, and we've been thinking through many of these issues. So I mentioned all these different longitudinal studies that are ongoing around the world that we're working with. It is rare. In fact, I don't know a single case where the scores on these tests have been shared with the participants of these studies. It's also the case in many of these daily diary studies. Now, what's very exciting here is that there are a number of applications out there that allow you to take these cognitive tests and get your scores and track your scores over time. And we're really working through that model now in our own research and in collaboration with physicians and providers, as well as discussing this with community members of what kinds of feedback can we give. And I think the most important thing that we'd like to give feedback on is the changes in your cognitive functioning as they relate to the kinds of health behaviors, the kinds of physical activities and things that you do, because this really does impact those test scores, both at the daily level, but across months and across years. And for you to be able to see those scores and see that what you do actually matters is, I think, a very important bit of information that really helps you to maintain that function, maintain that adherence. So we're really working through that kind of model. To my knowledge, it really hasn't been done from the research side or from the provider side so much. But certainly, there's a lot of things out there now available to do that yourself.
Yeah, and I think Dr. Hofer's also being humble. This is, in fact, one of his own areas of research as well. And so you may go and see a clinician, a clinical neuropsychologist. You may complete a test, and they may, in fact, compare your performance on that test to norms. And those norms would be based on cross-sectional data, and the comparisons would be decidedly between subject. So it's not comparing your performance to your performance yesterday, or better yet, your performance 2 years ago or 4 years ago. It really has nothing to do with you. It has to do with your performance relative to the performance of individuals who are of similar age, gender, and education, typically, which doesn't take into account lifestyle behaviors or many other things whatsoever. It basically ignores the individual. Dr. Hofer's work focuses on the individual, and we need to do that for several reasons. Somebody may present to a clinician and they tell them, oh, you're performing abnormally low. You're more than a standard deviation below what the norms are. Well, that may be due to a whole host of factors, and you might simply be what we would call a lifetime low performer. That's not necessarily a bad thing. Not meant to be pejorative. I actually see the plus in that presumably you've been stable the whole way. The stability is what I would want to see. Okay, here's the flip side. For all you overeducated people in the room who are 2 standard deviations above the mean and have actually dropped a standard deviation within the last year, you know it, your loved one knows it, but your geriatrician doesn't know it. Your clinician doesn't know it because they compared it to norms, and you're still doing brilliantly, but you're not.
Wow. That is a great point. That is an excellent point about what you've all spoken about, was not comparing to populations as a whole, but to yourself.
Absolutely.
That's a really good point I've got from this. So I've run out of time for questions. I will give one question to the panelists as you finish, and you can ponder how you're going to answer it. Probably this question was written by one of our octogenarians. It is smoking marijuana okay? Thank you very much, all of you. We don't have marijuana, but we have juice.